Hello, my name is Taylor Robertson, and I am an inpatient therapist at Baton Rouge Rehab Hospital. I am a certified brain injury specialist, and I also have a certificate in visual rehabilitation. Today, I will be discussing the evaluation and management of visual dysfunction following acquired brain injury. We will begin this educational series by first discussing who the visual team is comprised of. We will then review the basic anatomy and function of a normal visual system and the accompanying pathways to understand visual perception. We will also discuss the most common deficits or visual pathology one may encounter while interacting with patients that have sustained an acquired brain injury and understand the functional impacts that visual impairments can have on our patients. I will then teach you how to determine who might need a visual screening, how to complete a basic and quick visual screening, as well as provide some helpful tips to improve screening efficiency with complex patients. Lastly, I will provide a few easily implemented therapeutic interventions and environmental modifications that can be used to assist with the management of visual dysfunction across all disciplines. Studies show that 90% of all patients that sustain a head injury, whether traumatic or non-traumatic, are likely to experience symptoms of visual dysfunction. These symptoms include, but are not limited to, blurry vision, sensitivity to light, difficulty focusing, headaches, a reduction or complete loss of their visual field, and/or difficulties with eye movements. Attempting to complete even the most basic tasks like dressing, bathing, or walking with visual deficits can be extremely difficult and very frustrating for our patients. Therefore, it is not uncommon to notice an increase in unwanted or problematic behaviors such as fidgeting, irritability, avoidance, or even angry outbursts. Having a better understanding of the visual system and common visual deficits that can occur as a result of a brain injury can help you to better understand this problematic behavior and improve your confidence in not only managing these behaviors, but treating the underlying causes. I am sure everyone has heard of the saying, "It takes a village." This phrase essentially means that an entire community of people must provide for and interact positively with an individual in the population for him to grow. This concept can and should be applied for professionals treating patients that sustain a brain injury. The needs of a patient that has sustained a brain injury are so complex and diverse in nature, and let's face it, can sometimes be emotionally challenging, that it is nearly impossible for one discipline to assume sole responsibility for the entire treatment of that patient. Some forms of visual dysfunction can be subtle and may not be obvious to the family members or caregivers. Imaging such as CT scans, X-rays, or MRIs may not reveal deficits that are contributing to visual dysfunction. Therefore, the identification and management of our patients' visual deficits after brain injury is also a team effort, as some of our patients may only experience symptoms of visual dysfunction with certain tasks during specific times of day or in particular environments. As a team, we can work together to identify when unwanted symptoms occur, strategize to reduce these symptoms, increase our patients' tolerance to activity, and ultimately improve their independence across all areas of life. So, let's discuss the basics of vision. We often think about vision as simply being what we see and if what we see is clear. However, vision is much more than that. It also includes how our brain makes sense of what we see, otherwise known as visual perception. By definition, vision is a dynamic process of identifying, organizing, interpreting, and understanding what is seen to derive meaning and direct our actions. It is comprised of a complex foundation of pathways formed between the eyes and the brain. It is a learned process that is created during the prenatal period of life and refined through the first years of life. There are over 35 different areas in the brain involved with some degree of visual processing, which means there are more areas of the brain dedicated to vision than all other sense modalities combined. We rely heavily on the visual system for successful interaction within our environment. If this system is not working properly, it can greatly affect our balance, coordination, our ability to plan and anticipate movements. As a result, it may be difficult to care for ourselves or others, drive, work, manage finances or medication, sleep, or maneuver around our environment. In order to understand how visual dysfunction can be devastating to our patients, we must first appreciate how the eye functions in regards to movement, and then understand how the brain is able to receive, interpret, and convert light to a recognizable image that we can act on. The eye is considered to be a slightly asymmetrical globe that sits within a protective bony socket called the orbit. There are 6 extraocular muscles which are situated around the eyeball, located within the orbit and attached to each eye. These muscles are innervated by cranial nerves and are responsible for moving the eyes up, down, side to side, and rotating the eye. Therefore, if there is damage to the bony socket or to one of these cranial nerves by either direct or indirect trauma, it is likely that the eye will have difficulty moving in a particular direction and can ultimately cause unwanted visual disturbances such as double vision. The muscles of the eye are ranked among the strongest muscles of the human body. They are the most active, producing over 100,000 movements a day, and subsequently the most subject to fatigue. Therefore, whenever damage occurs to one of these muscles or the cranial nerve that innervates them, it can produce a litany of deficits that will impair a person's ability to function. This slide provides a brief overview of the 6 extraocular muscles, their action, as well as their innervation. Understanding the relationship between the muscles and their corresponding nerve can be extremely helpful and significant when completing a visual screening to identify possible eye alignment concerns or cranial nerve palsies. 7 of the 12 cranial nerves are involved to some degree with the visual system. Therefore, having a basic understanding of these interventions is helpful when both learning this information and applying it during assessment and treatment of patients. I recommend keeping a reference sheet of all the cranial nerves handy during this presentation and during a performance of the visual screening and treatment planning when working with patients with visual dysfunction, regardless of whether a brain injury has occurred. Now that we understand how the eye is able to move, we will next discuss how the eye functions to produce visual images that we can recognize and then act upon. It is important to note that all visual images initially begin as waves of light. The eye contains many structures that work together to allow specific amounts of light to enter the eye. First, light enters through the front transparent part of the eye known as the cornea and is directed towards the iris. The iris is a flat, colored, ring-shaped membrane behind the cornea of the eye. It has an adjustable circular opening known as the pupil, located directly in the center. The iris, through a process of constriction or dilation, will alter the size of the pupil, allowing specific amounts of light to pass through the eye. After entering through the pupil, light will then pass through the lens, a clear biconvex structure located behind the iris. The lens works together with the cornea to focus and direct light to the retina, located along the back of the eye. The retina is unique in the sense that it is a light-sensitive layer of tissue containing special structures called photoreceptors. These photoreceptors are localized around an area near the center of the retina called the macula and are responsible for high resolution and color vision. These photoreceptors are excitatory in nature and act to translate light into electrical signals through a process called phototransduction. These electrical signals are sent via the optic nerve and its intercortical pathways to the vision center of the brain located within the occipital cortex. The occipital lobe will then decode this electrical information from the retina and begin generating visual images that we can recognize and act upon. It is also important to know that we actually have 2 different types of vision that we rely on: central and peripheral. Central vision is what we see directly in front of us, such as when we read or attempt to recognize facial features, while peripheral vision is what we can see from the corner of our eyes without turning our head, such as when we drive or play sports. Damage to either one of these systems can be detrimental to function. In order for the electrical impulses to be processed in the vision center or primary visual cortex located within the back of the brain, they must pass through an intricate route of nerve fibers known as the visual pathway. The visual pathway is actually comprised of 2 parallel pathways, beginning with 1 optic nerve for each eye and then making its way to the back of the brain. Now, without overcomplicating this process and bringing back the wonderful memories of your neuroanatomy lectures, I will briefly highlight the most important features of this pathway. First, the optic nerve contains information from the left and right visual fields from each eye, respectively. You can see these 2 different fields depicted by colored lines within each eye, 1 red and 1 blue. That information is then sent through a network of structures featured in the image above. Information from the left visual field from each eye, indicated by the red pathway, will eventually join together through intercortical tracts to be processed in the visual cortex located on the right side of the brain. The same can be said for the information received from the right visual fields from each eye, which is indicated by the blue pathway. These travel to the primary visual cortex located on the left side of the brain. As you can see, the transmission of electrical signals along the visual pathway to the primary integration center located in the primary visual cortex is extremely complex. With a pathway so long and so wide, it is not hard to see how injury to any part of the brain could easily damage these pathways, disrupting vision and resulting in complete to partial visual field loss in one or both of the eyes, depending on the specific location of damage. Once the electrical signals are converted to visual images that we can recognize within the primary visual cortex, the information must then be sent to other areas of the brain for higher order integration. Higher order integration of visual information will occur along one of two parallel routes. The first route, the dorsal stream, is responsible for spatial processing and peripheral awareness. It is often referred to as the WARE pathway, beginning in the occipital lobe and passing superiorly through the parietal and frontal lobes. This pathway is involved with spatial awareness, guidance of actions by providing information on direction of motion, accuracy of movement, and depth perception. Someone with damage to this pathway may present with deficits such as hemispatial neglect, apraxia, or difficulty interpreting where they are in space. The second route, the ventral stream, is responsible for object processing and recognition. This is known as the WHAT pathway, and it begins in the occipital lobe before passing inferiorly through the temporal and frontal lobes, contributing to visual memory and form representation. This pathway allows us to recognize and differentiate between objects. Since this pathway passes through areas of the brain that function to control memory and emotion, someone with injury to this pathway may experience inability to recognize faces or objects. To further explain this in functional terms, let's say you're getting ready for work in the morning and you go to your closet to choose your uniform. As you look at your clothing, the ventral stream will help you recognize your work uniform from your everyday clothes. The dorsal stream will then provide you with the information such as how far you need to reach and in what direction you need to reach in order to successfully grab your uniform. Understanding the entirety of the visual pathway and the corresponding functions of the lobe as it passes through is important when treatment planning for our patients. We want to be sure that we implement appropriate interventions, as visual dysfunction may present differently depending on the area of the brain that was damaged. So what does visual dysfunction actually look like in practice? Let's say you've just been assigned a patient on the brain injury unit. If your patient is having issues with their vision, you might see one or more of the following signs. They may have difficulty reading or focusing on their phone, TV, or items within the room due to blurry or double vision or difficulty coordinating their eye movements. They may complain of the lights being too bright or the environment being too distracting. If they are unable to communicate, signs of discomfort may be shown non-verbally through behaviors such as fidgeting, withdrawal, avoidance of interaction, or increased irritability. Patients might have increased complaints of headache, nausea, or motion sickness. They may blink frequently, rub their eyes, or keep their eyes closed in certain environments. You may notice your patient has difficulty sitting unsupported edge of bed or exhibit a postural deviation in a certain direction when seating in their chair or even when they're walking. They may exhibit a head tilt or gaze preference. Visual problems commonly affect a patient's posture, balance, and interpretation of where they are in their environment. A patient might also make comments that the floor appears tilted or words appear as if they're moving on the paper. Finally, because vision is so critically important to our ability to interact with our environment, locate necessary items, and carry out functional tasks, someone with visual deficits may require increased time or assistance to complete self-care activities. Okay, up to this point, we have reviewed how the typical visual system functions. We discussed functional implications and common patient complaints a patient with visual dysfunction may experience after sustaining or acquiring a brain injury. Now, we will discuss a well-known framework in the visual rehabilitation world that can be referenced when evaluating and treating your patients. Mary Warren is an occupational therapist that created the hierarchy of visual perception. It is a developmental framework for the evaluation and treatment of visual perceptual deficits in adults with acquired brain injury. This framework is based on a review of research conducted on subjects that had a diagnosis of CBA and TBI. This framework, pictured in the slide, states that visual perception can be thought of as a hierarchy of skill levels that interact and subserve one another. Higher level skills evolve from the integration of lower level skills. A breakdown or deficit in any one of the lower level skills due to a brain injury can cause functional implications for our patient and affect performance. Application of this framework requires a bottom-up approach to evaluation and treatment, emphasizing identification and remediation of deficits in lower level skills. Let's say you have a patient who's been diagnosed with a severe left visual field cut. We know that encouraging scanning towards the side with the field loss is best practice. However, we must also consider other factors such as our patient's visual acuity and their ability to move their eyes within a functional range to ensure that scanning is effective. If we attempt to implement a scanning technique and our patients lack the ability to move their eyes fully due to the left due to muscle weakness, the hierarchy states that scanning will not be fully integrated or successful. When deciding whether or not to complete a visual screen on your patient that has a brain injury, it is important to consider your patient's overall cognitive function, baseline behavior, and level of alertness prior to administering the visual screen. Patients may not have adequate activity tolerance or attention span to complete a thorough visual screen on day one of the evaluation process. Majority of your initial findings will be based on your clinical observation skills. It should also be noted that patients that have sustained some degree of neurological damage will likely be prescribed medications to address other neurological symptoms, yet directly affect the ability for their visual system to work properly. You should discuss these concerns with a patient's prescribing doctor. As clinicians, we are trained in the skill of observation. A patient's performance with any functional task will often provide us with more than enough information about our patient's potential visual dysfunction, and also provide a possible starting point for intervention. For instance, during an evaluation, your patient looks at you and you notice one eye is drifting far outward. They are constantly squinting, complaining of frequent headaches in the brightly lit bathroom, and are unable to successfully reach accurately for their toothbrush. They present as being extremely impulsive and unable to attend to verbal instructions longer than 5 to 10 seconds. They appear to get increasingly agitated with verbal redirection. Attempting to perform a comprehensive visual screen at this phase in their recovery will most definitely end in frustration in both you and your patient. In this scenario, it is safe to assume that your patient is likely experiencing visual discomfort due to possible double vision, overstimulation, and decreased proprioceptive skills. We can begin our treatment plan by introducing compensatory interventions to eliminate or reduce the double vision through a patching technique we will discuss later, modifying the environment to decrease noise and light, and reducing extraneous visual clutter to improve overall activity tolerance. General rules that need to be considered when performing a visual screen, regardless of our patient's diagnosis, is to ensure that the patient is being tested in a well-lit environment. The patient should wear their most current prescriptive lenses if available, and the patient should be positioned in the best aligned and supported posture. If a patient has difficulty sitting upright unsupported, exhibits increased fatigue or dizziness when seated, they may need to be assessed supine versus seated in their wheelchair. Also, if you suspect any double vision or gaze limitation, it is best to complete all subtests of the screen on one eye and then repeat on the other eye. When working with individuals that have sustained a brain injury, it is important to remember that flexibility is key. In the following slides, I will go over a structured way to screen patients for visual impairments, regardless of diagnosis. However, when screening a patient with a brain injury, components of the visual screen may need to be deferred to a later date or modified to match the patient's current level of abilities. Lastly, remember, it is okay if the visual screen is done over a period of sessions, as the patient's tolerance to activity, environmental stimulus, and ability to follow instructions or communicate improves. The patient's comfort will always take precedent. We will now discuss how to perform a quick vision screen that can be easily implemented during your evaluation process. Ideally, performing the actual vision screen should only take about 5 to 7 minutes and is meant to be used in conjunction with symptom reporting, balance testing, and functional observation to provide accurate clinical picture of your patient. As practicing clinicians, our role in vision is not to make an official diagnosis of what our patient is experiencing. We administer the screen to determine the presence of possible visual deficits that may require a more thorough evaluation by a trained professional or doctor, such as an optometrist, PM&R doctor, ophthalmologist, at a later date. Often, our patients will have a significant amount of time between admission to our hospital and a follow-up appointment with a visual specialist. If our patients are experiencing uncomfortable symptoms related to their visual impairments, it will directly affect their participation and progression in therapy. As therapists, we can work together to identify and reduce the likely cause of discomfort through compensatory techniques and remediation, if appropriate, until the patient can follow up with their primary care or eye doctor. Keep in mind when performing visual screening to always monitor for signs of discomfort and to ask patients to rate their symptoms of visual discomfort, such as headache, nausea, or dizziness, on a scale of 0 to 10 prior to the start of their screen and monitor periodically throughout. As you can see, a visual screen is comprised of many parts. Let's talk about the individual task components involved in a visual screen. As with all screenings and assessments, a thorough chart review and patient interview is necessary. If the patient is not a good historian or communicator, then reach out to a close family member or caregiver. During a chart review, consider the time of the injury, whether the injury was traumatic or non-traumatic in nature. Was there direct eye trauma involved or indirect eye trauma through the increased intracranial pressure, hydrocephalus, skull, or facial fractures? Have they had any prior brain injuries? When did the patient have their last eye exam? Do they use corrective lenses, and are they using their most current prescription now? Have they had any other prior eye surgeries that might impact the eye's ability to function, such as cataract removal, LASIK, or eye alignment surgery? Or do they have any other diseases or disorders that might affect eye health, such as a history of seizures, MS, Parkinson's, diabetes, CP, macular degeneration, or glaucoma? In addition to a thorough chart review and patient interview, we also must rely on our skills as trained clinicians to identify possible signs of visual dysfunction based on our patient's presentation and performance in functional task. Oftentimes, a patient may be unaware that they are experiencing visual dysfunction. This could be due to decreased insight to deficits as a result of the brain injury. The visual deficits may also be so minuscule that the patient is unaware of the cause of the symptoms, or the symptoms might be confused for another medical condition or complication following head injury. We've talked about a few potential signs you might observe if a patient is experiencing visual deficits, but let's also consider how their eyes present when you are engaging with your patient. For instance, what color is their sclera? A healthy sclera should be white. However, a person with excessive eye strain or dry eye might appear red and irritated. A person with an underlying medical condition might appear yellow. It is also important to make note of any abnormal color and any changes that you can report to your medical team. Observe how your patient's eyelids look in relation to one another. Are they symmetrical, or does one appear fixed, open, or shut? Do their eyes appear to move symmetrically and sit evenly at rest, or does one tend to deviate to the side? All of these considerations are important in the proper identification of potential causes for visual dysfunction, and then can help us make the appropriate follow-up referral. After completion of the chart review and patient interview, we must then look at our patient's visual acuity, both at a distance and near. Visual acuity refers to the sharpness or clearness of vision. When our vision is clear, it allows for a stronger signal to the occipital cortex and then other parts of the brain for improved processing. The most common screening tool, the Snellen eye chart, utilized in practice, is one that we are all familiar with. As therapists, we are not going to focus heavily on the number or score of the acuity screen, as we are not diagnosticians. This score or number is solely used for referral purposes. We are going to be more interested in how changes in our patient's visual acuity might be impacting their function in everyday life. We are going to pay extra attention to our patient's behavior during the screen while listening for signs of discomfort or difficulty recognizing what we are asking them to identify. To best note this behavior, always pay attention to the patient, not the chart, while they are performing the visual screen. This will provide information on how our patient is seeing and interacting with their environment. From there, we can make the appropriate modifications to improve performance. To test distance acuity, have the Snellen eye chart positioned on a vertical surface with the patient seated 10 feet away. Have the patient wear their most current prescriptive lenses. You will test one eye at a time and then both eyes together. With one eye occluded, instruct the patient to read the line containing the smallest letters they can see. They will continue reading down the chart until they reach the end or report that they can no longer see clearly. You are observing for the line in which the patient has 2 errors. This is going to be their distance acuity score. You will then occlude the opposite eye and repeat the test, and then repeat both eyes together. After assessing distant acuity, you will look at the patient's near acuity. This also is referred to as reading acuity and is important because it will provide insight to how our patients might respond to a written HEP, operate their phone, or read a newspaper. There is a reduced Snellen eye chart meant to be used when assessing near vision that can be found and printed online. To assess for near acuity, complete the same process as above, but using the reduced chart placed only 16 inches from your patient's face. Once again, observe for the line at which they have 2 errors and record this as their near acuity score. A score of 20/40 on either acuity portion would warrant a referral to an eye doctor. However, if you observe any abnormal behaviors or difficulty completing either portion, we would also want to refer to a trained professional. When assessing acuity, remember to watch your patients for any signs of discomfort or any behavioral or postural changes that might indicate difficulty or deficits in vision. Slowness of response may not necessarily mean that the patient lacks visual acuity. It could also mean that the test needs to be modified due to other deficits, such as attention or cognitive endurance. We can assist by reducing distractions, by presenting only one letter at a time, using a test that contains recognizable images or letters, or by having a patient nod if the symbol is clear. It should be noted that a person with a TBI will often have increased difficulty with near vision, while a patient with a primary diagnosis of CVA will more often than not experience changes in their near or distant vision. Also, never assume that the corrective lenses used before injury are still appropriate for the patient post-injury. As you know, patients that sustain a brain injury may present with deficits that impact their attention, ability to communicate, or ability to recognize images. Some patients will also have varying degree of literacy levels. If your patient is unable to be assessed with using the Snellen eye chart, you have other options for tools that may be more appropriate for patients with these deficits. Some screeners contain shapes, alternating direction of the letter E, or other things. We can also modify this component of the visual screen by simply asking our patient to complete a functional reading task. For instance, ask the patient if they can identify larger signs within the gym or room numbers along the hallway. We can ask them if they can read a newspaper article, text message on their phone, or read a medicine label. We would just have to be specific on the evaluation and note that the functional visual acuity is suggested to be intact or impaired until a more formal assessment can be made. At the end of the day, we just want to know if our patients can successfully interact with their environment. If a visual acuity deficit is noted, the first step in intervention is to refer the client to the appropriate eye care specialist to determine if visual acuity can be restored to the normal range. As therapists, we can determine which activities are limited by the reduction in visual acuity and then set goals to regain independence in ADL's immobility by using various low vision strategies through compensation and modification versus remediation. We should always make sure that our patients are wearing their most current prescriptive lenses. If the patient does not have them, we should ask family members to bring them in. Drugstore readers can be trialed in therapy to improve visual acuity until the patient can get into an appointment with their eye doctor. Reduced visual acuity may create difficulty with reading small print. When providing handouts containing instructions or information, like an HEP, we should increase the text size and utilize a high contrast option, such as black writing on white paper. You can also assist the patient and family with making appropriate modifications on their phone or medication labels to increase the size of the text. When providing training on self-care skills or mobility, we should emphasize the importance of increasing visibility of the patient's environment by utilizing high contrast options, such as differentiating the color of the object the patient is interacting with from the background, such as using a black cup for milk or a white cup for coffee. Introducing colored tape that can be applied to the edge of the stairs to indicate changes in threshold height can be helpful for these patients as well. Lastly, education to the family on increasing lighting within the home, establishing a routine, reducing visual clutter, and simplifying the amount of items in patients' closets, drawers, shelves, and countertops to containing only the essential items can help reduce the frustration and improve patient performance in their home environment. Visual fixation is the voluntary ability to maintain visual gaze on a single target in all directions without extraneous eye movements or loss of focus, such as maintaining eye contact when someone is talking to you. In a typical adult without brain injury, he or she should have no difficulty in selecting objects within their environment and focusing their gaze on it. A patient who is experiencing deficits in fixation will have an inability to obtain object fixation and/or an inability sustaining it. It can be associated with or occur separately from spatial or hemi-body neglect or inattention. Poor fixation will result in off-task behavior that can give the impression that the client is inattentive or impulsive. Begin screening for this by holding a target approximately 16 inches from a patient's nose. This target can be a pencil with a bright-colored eraser, a pen light for lower-level patients, a fixation stick, or even an object of interest or importance to your patient. Instruct the patient to simply stare at the target. The patient should be able to maintain fixation for at least 5 seconds. You should observe the time the patient is able to maintain fixation and record the quality of fixation as either steady or unsteady. This step can be repeated by placing fixation items in various visual fields. Continue to monitor the patient for any outward signs that suggest difficulty with fixation, including nystagmus, one eye drifting out, excessive blinking, or losing target and then returning to midline. For someone with a brain injury, they may be unable to understand the instructions of the visual screen. Therefore, you can simply present an object of interest or pen light at their midline and observe if the patient is able to fixate on that item. The next ocular motor skill we will assess are pursuits. Smooth pursuits are eye movements that allow us to keep an image steady on the retina when following a moving target, such as when we are watching a football player run across the field. These movements are slow and are essentially the motor expression of attention. In order to assess pursuits, you will present a target 16 inches from the patient's face at midline. You will instruct the patient to watch the target as it moves without taking their eyes off of the target. You will then move the target clockwise for 2 rotations and counterclockwise for 2 rotations. Someone with intact pursuits should be able to follow the complete rotations with smooth and coordinated eye movements. You should watch for difficulty keeping their eyes on the moving target, limitations in range of motion in one or both eyes, eye movements that appear jerky or choppy, compensatory head turns to keep eyes on the target versus eyes moving with the target, any nystagmus, and/or excessive or uncoordinated eye movements. You should also listen for complaints of double vision. You will then record the quality of the pursuit as poor, fair, or good, and then can further classify the pursuit as smooth or jerky. Visual fixation and pursuit dysfunction can be retrained by teaching your patient how to scan efficiently and attend to spatial details within their environment. The normal or typical scanning technique for near or up-close tasks will generally follow a left to right and then top to bottom pattern. When looking for items at a distance or in the peripheral, you want to encourage your patient to perform scanning through a sweeping clockwise pattern. We can encourage this in therapy by having our patient perform functional activities that require effective scanning to complete the task. For instance, if you are a speech therapist assessing swallowing during mealtime, you can encourage your patient to scan their tray to locate specific items on the tray. Remember, functional activities chosen for the patient should be directly related to their goals. This will improve patient buy-in and likelihood of carryover of scanning strategies. Functional activities that can be used by any discipline might include sorting silverware from the dishwasher to the drawer, sorting coins from the coin holder, retrieving and sorting laundry by color, scanning the room or gym for specific items, providing the patient with a list of specific grocery store items and having the patient retrieve them, or even locating names or prices of ads in a newspaper. Speech therapy may choose to address these deficits through pen and paper tasks, such as letter recognition and cancellation, while having their patient read a newspaper or having a patient locate specific items on their tray again, while also assessing swallowing. Occupational therapy may address a patient's ability to scan and fixate on specific items during their self-care routine, such as a toothbrush on the counter or a specific colored blouse in the closet. Physical therapy can ask their patients to search for specific items in the environment while completing the functional mobility portion of their evaluation. If scanning and walking presents too much of a challenge, then the task can be modified to have a patient locate an item while they're sitting or laying down, and then progress to walking. We can also compensate for our patient's deficits by incorporating anchors, such as a red tape, to cue where to begin a visual search, providing cues about the speed of their scanning to improve performance, and reducing any visual clutter or moving patients' desired items closer together. We also want to provide education to family members on strategies to improve patient safety within the home, such as reducing visual clutter, establishing a daily routine, placing those commonly used items in the same spot after use, and then removing things that are not needed or not being used and limiting distracting stimuli when completing a task that requires focus. The next area of oculomotor control that is likely to be impaired will be saccadic eye movements. A saccade is a single rapid conjugate eye movement that enables us to redirect our focus and line of sight from one target to the next. An example of this would be watching a train pass in front of you and you shifting your focus from one cart passing to the next. We rely heavily on an intact saccadic system to keep our central nervous system updated on all objects within our visual field, as anything that occurs within our periphery and attracts our attention will elicit a saccadic eye movement in that direction. How a brain injury might affect a patient's saccadic response will differ depending on the location of injury. A patient with frontal lobe injury might lack the ability to suppress saccades and cannot help but attend to something that catches their interest, appearing to us as them being flighty or impulsive. Whereas someone with an injury to the parietal lobe might be unable to break fixation or have difficulty even generating a saccade response. Therefore, they appear flat or disinterested. Someone with a pontine or cerebellar injury might have difficulty coordinating saccades and present with overshooting or undershooting. When screening for a saccade dysfunction, you will begin by presenting two horizontal targets approximately 4 to 6 inches apart from one another and 16 inches from the patient's face. You will ask the patient to look at one target and, when instructed, quickly look at the other target. You will repeat this in a non-predictable pattern for approximately 5 cycles. You can also repeat this process by placing the two targets vertically at midline. If your patient with a brain injury has difficulty following instructions, considering using 2 pen lights as targets, turning on one light at a time while providing verbal cues to switch gaze and observe for the saccadic eye movement. You will observe the quality of the eye movement and record it as either poor, fair, or good, and note the accuracy of the saccades by indicating if any overshooting or undershooting occurred, and if so, did it occur to one side specifically, or did it occur to both? Also make comments on any compensatory head or body movements needed to locate the target. Interventions to improve saccadic eye movements are generally focused on improving the quality, accuracy, and speed of movement. One way to begin to address saccade dysfunction is by incorporating opportunities for patients to alternate their gaze between 2 different objects within an activity during the treatment session. With saccade training, you should begin by having the 2 objects closer together with minimal visual stimulus between the 2 items to improve accuracy of the patient locating the desired target. For instance, have the patient standing or sitting in the kitchen while instructing them to shift their focus between 2 items on a shelf or counter. You can increase the complexity of the task by spreading the items farther away and eventually adding distractors or other items on the shelf. The same principle can be applied when performing functional mobility or bed mobility by having patients shift the focus between 2 cones on the floor. When possible, we want to utilize a multimodal sensory approach when retraining visual skills. You could add a vestibular and motor component by having the patient stand on a balance board while tapping targets on a wall, or sitting unsupported to tap a balloon or bubbles. Worksheets containing saccade pyramids or column jumps can also be introduced to patients to learn basic foundation of performing saccadic eye movements. These also make a good choice for a home exercise program and can be easily found online. Computer retraining software, such as the Bioness Integrated Therapy System, or BITS, has been utilized in major hospitals across the country and has shown promising results in retraining patients' ocular motor control, assisting patients with visual field loss, visual neglect, enhanced eye-hand coordination, visual reaction time, and cognition. A proposal has been submitted to bring the BITS to the Baton Rouge Rehab Hospital as part of our brain injury unit and will hopefully be utilized as a tool for all clinicians to remediate functional deficits that are occurring due to poor ocular motor control. As noted with fixation and pursuits, the same compensatory strategies can be utilized for saccade dysfunction. These include anchoring and reducing visual clutter and visual distractors within the environment. Ocular alignment is crucial to the coordinated function of both eyes and visual processing in general. Ocular motor misalignment can occur as a result of damage to the extraocular muscles, cranial nerve, or even the brainstem. Patients with ocular alignment impairments will typically close one eye, ask for a patch, or develop an awkward head turn to reduce symptoms. They may also complain of double vision, vertigo, confusion, appear clumsy, have motion sickness, and/or poor spatial judgment. To screen for ocular misalignment, you will begin by presenting a target or object of interest at the patient's midline, approximately 16 inches from their nose. You want to observe the location of the pupils as they look at this target. They should be symmetrical in nature unless they have a history of ocular misalignment. You will then instruct the patient to watch the target as you move it. You will move the target in all 9 cardinal directions of gaze by making an X and then a T. Again, observe for symmetry, abnormal compensatory head movements and body movements, and/or impaired range of motion in the eye movements. If able, instruct the patient to verbalize if they begin to experience double vision in any direction of gaze. Repeat this process again by including one eye and then repeating with the other, observing for any range of motion limitations in any direction of gaze. You will score the patient's ocular alignment as intact, impaired, or unable. Be specific in the areas in which you notice limited range of motion and if you notice any eye deviation at rest or with movement. As mentioned, a patient that has sustained a brain injury is at increased risk for cranial nerve damage, resulting in an ocular misalignment. Patients that have sustained cranial nerve damage will experience partial weakness or complete paralysis of the areas served by that affected nerve and have a very specific presentation upon evaluation. Feel free to utilize this slide as a reference tool during administration of the vision screen to assist in the identification of possible cranial nerve damage and to prompt you to seek collaboration with the patient's doctor or vision specialist. Therapists, regardless of any experience level in visual rehab, you should never be attempting to address or treat cranial nerve palsies due to the risk for further damage. Always refer to a specialist with a suspected visual cranial nerve palsy. The main complaint someone with impaired eye alignment will have is double vision. However, sometimes a patient may have an obvious misalignment but is not complaining of double vision. If this is happening, their brain has generated its own way of compensating for the injury by suppressing visual input from one eye. We do not want to attempt to fix this specific misalignment because we could essentially cause the brain to unsuppress the images and create permanent double vision. However, if you suspect someone has double vision or the patient is reporting double vision, it is important to bring this to the doctor's attention. Treatment of double vision requires an interdisciplinary approach and requires a referral to a qualified health professional who specializes in eye health, such as an optometrist, ophthalmologist, or vision specialist. If established, after collaborating with the PM&R physician or consulting with a visual specialist, that the problem is due to a muscle imbalance, then eye exercises can be initiated. Active range of motion exercises, or eye stretches, should be done in the direction of the weakness and performed one eye at a time. Tactile and verbal cues can be used to strengthen the response of the stretch. When addressing double vision, our goal as therapists is to maximize patient comfort by eliminating the double vision in order for our patients to be successful and independent as possible with their activities of daily living and navigating within their environment. This can be done through a technique called patching, which will be discussed more in a moment. More importantly, we want to provide education to the patient and their caregiver on the importance of carrying over patching techniques at home, environmental modifications to improve patient performance, and the need to follow up with a visual specialist to monitor and facilitate recovery. Historically, an occlusive eye patch has been utilized in the treatment of lazy eye. It is more common in children with congenital eye misalignment, but also has been utilized in the adult population that has acquired eye deviation, resulting in double vision. The eye patch would typically begin on the strong eye to strengthen the weak eye and would need to be worn for majority of the day. However, newer research has shown that the occlusive eye patch can possibly do more harm than good in those individuals with acquired diplopia or double vision due to brain injury. As we learned earlier, the optic nerve is responsible for receiving and interpreting light from both our central and peripheral vision, both of which are very important for our successful interaction with our environment. An occlusive eye patch may eliminate double vision for our patients, but it also reduces the amount of peripheral light entering the eye and thus reducing our patient's peripheral awareness. This could potentially cause our patients to appear clumsy, have difficulty judging and anticipating their movements, and also increase the possibility of falling. A new method of treating diplopia, the spot patch, has been successfully implemented in the adult neurological population. It is a technique that eliminates diplopia without the limitations and side effects of traditional patching. Depending on the positioning of the spot patch, it can be used as either a compensatory technique to eliminate double vision or a retraining tool not only to eliminate double vision but also to restore alignment. In this module, we will only discuss the compensatory spot patch technique to eliminate double vision in our patient population, as placement to restore alignment is more complex and outside the scope of this education. The purpose of the spot patch is to prevent total occlusion of one eye by only blocking the position of gaze that produces diplopia and allowing for improved perception of light and increased peripheral vision for balance. If the patient has double vision with straight ahead gaze, try placing a circular piece of translucent tape on the inside of the glasses in the center of the lens of the affected eye. Some patients may only experience double vision whenever they are fatigued. If this is the case, have your patient only wear the lens patch when they are tired to reduce symptoms, allowing your patient to build endurance throughout the day. A second pair of glasses is helpful if needing to remove the patch frequently. If your patient is experiencing double vision when looking in a particular direction due to a muscle imbalance or weakness in one eye, such as when he or she is looking to the right, then have the patient look in that direction and place a strip of tape vertically over the pupil of the affected eye. This blocks central visual input in this direction and also can help reduce double vision. You may have to begin with a larger piece of tape on the lens and then slowly trim the tape down as strength in their eye improves or as they can tolerate increased activity with the lens. Once the patch is applied, have the patient perform a functional mobility activity or ADL task with and without the lens to determine if the spot patch is effective in improving functional performance. It is important to work closely with a medical professional or vision specialist when determining the best position to place the spot patch, as patching requires ongoing monitoring and adjustment. Spot patching may take some trial and error as you work to identify the best placement and size of the tape to reduce your patient's complaint of double vision. The main principle is to assess your patient's eye range of motion, observe for limitations, and identify the position of gaze that elicits double vision. Remember, a little occlusion goes a long way. The last piece of oculomotor function that we will cover is the reflexive function of the vergence and accommodative system. These systems are responsible for coordinating movements of both eyes to allow binocular fusion and create a clear image. When looking at an object up close, the eyes will rotate towards each other. This is known as convergence. When looking at an object farther away in the distance, the eyes will rotate away from each other. This is known as divergence. Accommodation is the process by which the refractive power of the eye changes to ensure we see a clear image by altering pupil and lens shape, regardless of the distance of the object we are looking at. The most common way to observe for vergence dysfunction is through the near point of convergence test. You will begin by sitting directly in front of your patient, holding the fixation target or object of interest 16 inches from their face at midline. You will instruct the patient to stare at the target. We want to make sure that the target is single and clear at the start of the test. You will ask them to continue staring at the target while you slowly begin to move the target towards their nose. Inform the patient to let you know if the target becomes blurry or doubles while you observe for any eye deviation. You will measure the point in inches at which the vision breaks or becomes double. This is known as the breaking point. Lastly, you will slowly move the target back out and ask the patient to let you know when the target becomes single again. Measure this distance in inches and record it as the recovery point. A typical adult should be able to converge within 4 inches and recover within 6 inches. However, Older adults will have a greater distance for near point of convergence due to the normal pathology that occurs with age. The lens becomes less flexible and unable to accommodate as efficiently as aging occurs. Someone with a brain injury may have trouble following these instructions, so once again, we must rely on our skill of observation. You can prompt the patient to look at a near target and then a target at a distance while you observe for the symmetrical and synchronous movement of their eyes. If a patient has impairments within their vergent system, you might observe a delay in the speed at which the eyes are able to converge and/or diverge. You may observe one eye drifting out or observe your patient rubbing their eyes in efforts to produce a clear image. Make note of these observations on your evaluation. It is key to note that one of the more common visual dysfunctions a patient may experience after an acquired brain injury, in addition to double vision, is accommodative insufficiency. The patient will likely complain of headaches when completing near tasks and appear to have decreased concentration or comprehension. Normally, accommodation and convergence are automatic, but for those that have a brain injury, the patient may have to focus with a great deal of conscious effort to clear blurred images, potentially exacerbating symptoms and stress. The goal for interventions that address accommodative and convergence insufficiency is to improve focus flexibility to maintain a clear image at both near and far distances. The easiest way to implement vergence retraining is by incorporating opportunities for your patient to shift their gaze between two objects at two different distances, one near and one further away. This can be extremely effective when paired with a functional task and are referred to as near-far jumps. You may have to begin with two objects that are closer together and eventually grade the task by increasing the distance. You can also have the patient increase the speed with their shifting gaze and also increasing the number of repetitions that are completed to improve ocular endurance needed to improve performance in everyday activities. Pencil push-ups can be completed by having the patient hold a pencil about 15 inches from their face. The patient will slowly bring the pencil closer to the bridge of their nose until the image doubles. Have the patient stop here and attempt to focus to make the image single again. If successful, then they will move the pencil closer to their face. If not, they will slowly move the pencil back until the image is single again. You can have them repeat this process up to 10 times. Compensatory efforts may need to be made for our patients to reduce the conscious effort needed to maintain a clear image. This can be done through reducing visual distractions or clutter, adjusting lighting to patients' comfort and reducing glare, and providing education on carryover within the home. Finally, the last component of the visual screen is the assessment of visual fields. Visual fields allow us to orient specific spatial areas and can be defined as the field of view of the external world that is viewed by both eyes without turning our head. We need both central and peripheral vision to be intact in order to have a full field of view. A normal visual field is considered to be approximately 60 degrees superiorly, 75 degrees inferiorly, 100 degrees temporally, and 60 degrees nasally. When there are impairments in any portion of the visual field, there are specific functional deficits that we, as therapists, need to be aware of so we can better educate our patient and their caregivers to assist with their functional performance. For instance, impaired peripheral vision will affect our patient's ability to safely ambulate, be aware of their environment, and drive safely. Impaired central vision will cause impairments with identifying visual details needed for performances such as reading. Inferior visual field loss will create difficulty with balance and mobility, increasing their risk for falls. And superior visual field loss is correlated with decreased reading and writing abilities and difficulty identifying overhead obstacles. Depending on the location of injury within the aforementioned visual pathway, you can expect to see a variety of visual field deficits, including total vision loss in one eye, homonymous hemianopsias, quadrantinopias, and/or scotomas, or areas of decreased sensitivity. The preferred way to assess visual fields is through the two-person confrontation test or kinetic test. We should note, however, that this test can sometimes be insensitive and we should use the results as a way to rule in a visual field problem, but not necessarily rule one out. Prior to administering this test, we should consider the physical and cognitive abilities of our patients. This test requires good fixation, high level of concentration, and attention. If these skills are not present, this test will be extremely difficult to assess for accuracy and may need to be reserved for a later date. To complete the two-person confrontation test, you will be seated approximately 20 inches in front of your patient while another examiner is positioned behind them. You will keep your gaze on the patient as you are also observing for when the target enters your visual field, and your answer will serve as a control for the patient's response to identify any potential problems in visual field awareness. Begin by instructing the patient to keep their head vertical and maintaining fixation on your eye. The second examiner made to assist with the positioning of the patient's head. You will occlude one of the patient's eyes and explain to the patient that a target will be introduced from the side and they should report as soon as they see the target. For patients with a brain injury, a pen light or brightly colored object may easily be recognized compared to a regular pen or examiner's hand. The second examiner will begin in the 12 o'clock position and slowly move the target straight down until the patient reports seeing it. Compare the patient response to yours. If the patient cannot see the target as soon as you can, this can be an indication of a potential problem. The second examiner will then move the target clockwise and present at 2, 4, 6, 8, and 10 o'clock. Record approximately where the patient reports seeing the target in each visual field. You will then cover the opposite eye and repeat the test. The therapist should report findings as either gross visual fields are intact on confrontation testing or reduced visual field observed during confrontation testing. Findings from the confrontation testing should always be supported by observing the patient for potential visual field loss during functional task. For example, we may notice that a patient changes their head position when asked to look for something in a specific visual field, consistently bumps into objects on one side, misplaces objects in one field, or is having errors in reading by missing or misreading the beginning or ends of words. In addition to visual field loss, patients with brain injury may also suffer from visual inattention or neglect. It can sometimes be difficult to discern if a patient has visual field loss or visual field neglect, as they can occur with or without one another, and patients will present functionally very similar, with difficulty crossing midline, eye movements that are reduced towards the impaired field, bumping into objects, or not attending to objects on a specific side. They can also adopt abnormal head and body positions away from the impaired field. It can be incredibly difficult if your patient also lacks the awareness of their visual field deficits. One way to assess whether or not your patient is presenting with a visual field loss and/or visual neglect is through the extinction test. To complete this test, you will be seated across from your patient. Instruct your patient to stare at the bridge of your nose and keep their head still. Inform the patient that you will hold up a number of fingers in either one or both hands, and they will tell you how many fingers they see. You will begin by extending both your right and left hand in the 3 and 9 o'clock position in a fist simultaneously. You will then hold up a certain number of fingers in your right hand while maintaining a fist on your left hand and ask for the patient to respond. Then present a certain number of fingers in your left hand while maintaining a fist on your right, and again observe for the patient's response. Lastly, you'll present a number of fingers on both hands and observe for your patient's response. If a patient has a visual field loss, they will be consistent with their response and be unable to identify the number of fingers presented on the hand located within the lost visual field. However, if someone has a visual field neglect or inattention, they will likely be able to accurately identify the number of fingers presented on both hands when presented individually, but be unable to accurately report how many fingers are raised when presented at the same time, as they will ignore the neglected side. If you have a patient diagnosed with or exhibiting symptoms of a visual field loss or neglect, these are a few things you can do to help your patient not only function with their visual field deficit, but begin to recover. The goal of treatment for these patients is to increase awareness to the forgotten side to help them compensate for the damage to their visual field. We also want to make sure that we are setting up the environment appropriately to increase the patient's interaction with objects on both their affected and unaffected sides. Initially, you should address the patient on their good side or uninvolved side to ensure that you have their full attention and understanding. As they recover and their awareness begins to improve, you can and should start addressing them on their weaker side to provide opportunities for carryover of these scanning strategies. A common strategy we implement in therapy to increase awareness to the forgotten side is through scanning. We want to educate our patients on how to implement a proper and organized scanning pattern, typically following a left to right and top to bottom approach, to allow for efficient information gathering and processing. Research shows that patients with understanding of their deficits have a greater chance of success to compensate for their visual field loss. However, patients that have impaired awareness to their deficits will have a harder time implementing these techniques. As therapists, it is our job to utilize a multimodal sensory motor approach to reinforce the neglected side and provide as many opportunities as possible to bring awareness to their neglected or lost visual field. We can set up scanning courses when ambulating patients throughout the gym or outside to encourage head turns, pivots, and saccades towards impaired sides to locate specific items or cars. We can have the patient locate and retrieve items in a simulated grocery store positioned in the neglected field, or complete newspaper scanning to locate ads positioned on the impaired side. Making sure to always set up the room or environment to encourage carryover of scanning into the neglected field is crucial to recovery. You should be placing all non-essential but motivating items into the neglected side, such as the television, radio, or even setting up the bed so the window is on the patient's weaker side. However, to ensure our patient is able to easily call for help when needed, always ensure the patient's phone and call light is placed on their good side, and the patient is able to verify to you where the call bell is located. Meal times can be particularly difficult for patients with visual field deficits. If they will be eating without direct supervision, always set up the tray so that the food items are placed within the patient's intact visual field to ensure that they are achieving adequate nutrition. If you will be sitting with the patient, try to come up with a strategy with either verbal cueing or anchoring to enable the patient to scan to their weaker side and locate food on the entire plate or tray. Caregiver education and family training is also extremely important. We should emphasize importance of home and environmental modifications to improve a patient's safety within their home, as well as provide strategies for families to assist with the carryover of scanning techniques. We will now discuss 2 common conditions you may encounter when working with patients that have sustained a brain injury and that we should be aware of. The first is photophobia. This is also known as extreme light sensitivity. Due to the damage along the visual pathway and processing centers in the brain is unable to regulate or properly interpret the amount of light entering the eye, resulting in light sensitivity and creating an overwhelmed feeling in the patient. A patient with light sensitivity will often present with difficulty keeping their eyes open in brightly lit rooms such as the gym, dining room, or even when sitting at the nurse's station. They may have difficulty focusing on self-care or mobility tasks, or express difficulty with reading. They may often rub or squint their eyes, have increased tear production, or complain of seeing bright colored spots or have eye pain. It is not uncommon for these patients to refuse therapy, exhibit increased irritability, and appear non-compliant with staff. The 2 most important strategies in the management of photophobia are protecting the patient's eyes and modifying the patient's environment. We can easily reduce a patient's complaint of visual discomfort by adjusting lighting within the patient's room or the gym to a level that is comfortable for the patient and observing their response to these changes. This can be done by dimming the lights or turning off the overhead fluorescent light and opting for opening the blinds instead. We can also reduce the amount of visual clutter within the patient's room by removing unnecessary items from the bedside table, keeping linens tidy, and the closet organized. As therapists, we can collaborate with medical professionals and vision specialists to introduce tinted or colored lenses to a patient with potential photophobia to reduce symptoms of visual discomfort. Research has shown that lenses with orange or rose tint decrease migraines and reduce symptoms of visual discomfort following brain injury. Other colored lenses that have shown promise for reducing symptoms following brain injury are blue and green. We should monitor patient performance in ADLs and functional mobility while wearing these lenses to monitor for effectiveness of symptom management. The second common condition you might encounter when working with patients that have sustained brain injury is post-traumatic vision syndrome, or PTVS. The insult to the cortex produced from a brain injury causes stress to the central and autonomic nervous system, often leading to an interference with the ambient or peripheral visual system. As we mentioned previously, peripheral vision is responsible for detecting events in the environment and providing information to the patient regarding their balance, location in space, and distance from objects. It is the primary mode of vision responsible for functional mobility and works in connection with proprioceptive, kinesthetic, tactile, and vestibular system. Therefore, patients with PTVS will have vision that becomes more centrally focused, with difficulty processing visual input from their periphery. They may mistakenly perceive movements of stationary objects and find that environments with lots of movement are overstimulating. Other characteristics include the presence of an eye turn with or without complaints of double vision, accommodative dysfunction, convergence insufficiency, poor fixations and pursuits, and spatial disorientation. These patients may appear to have poor concentration and lower attention spans, complain of tunnel vision, motion sickness, or light sensitivity. It is also not uncommon to see a patient with PTVS experience a visual midline shift or develop abnormal posture away from their midline, as their perception of midline relies heavily on an intact kinesthetic, proprioceptive, and ambient visual system. PTVS is the most common visual dysfunction after mild traumatic brain injury. However, the symptoms and impact on life are anything but mild. Unfortunately, detecting the possible presence of PTVS is solely based on a patient's presentation when completing the visual screener, as current imaging, such as a CT or MRI, will not be able to detect PTVS. Remember, if you suspect your patient has PTVS, discuss your findings and concerns with a medical professional or vision specialist to determine the best course of treatment while the patient is under your care. If you are treating a patient in either outpatient or day treatment, stress the importance of following up with a visual specialist because if left untreated, the patient is at risk for experiencing dysfunction for many years. Initially, for patients with PTVS, it may be helpful to trial a bitemporal patching technique to reduce the peripheral information entering the visual processing system and thus increasing the patient's ability to focus and tolerate activity. Bitemporal patching can be done by applying tape to glasses or lenses to include the outer whites of both eyes and part of the iris. We want to make sure not to block the pupil to allow for central vision to enter the eye. Once the patient's ability to tolerate therapy improves, you can then trial a binasal patching technique to reduce patient symptoms and increase the patient's processing and integration of stimulus in the peripheral visual system. Binasal patching can be done by placing tape on patients' glasses or lenses to include the inner whites of both eyes and part of each iris, while again not covering the pupil. This reduces visual sensitivity and improves tolerance to motion. You should have your patient complete functional task and mobility with and without the occlusive lenses to determine the effectiveness and symptom production. The width of the patch and angle of the patching may need to be adjusted periodically as this patient's symptoms begin to improve. We want to use the least possible amount of tape to reduce the patient's complaint of visual discomfort. When trialing these adaptive lenses, we want to begin implementing it in only therapy with functional task to ensure effectiveness and then expand the wear schedule as tolerance improves. All right, guys, you did it. You've made it to the end of this module on visual rehabilitation. I now hope that you have a greater appreciation for the visual system and understand why visual impairments are common in neurologically impaired adults. I hope you realize how easily this system can be injured and how the effects are extremely devastating to our patients and their ability to complete the most basic activities of daily living and mobility skills. I hope you feel more confident about performing a visual screen with your patients and generating a starting point for interventions based on the visual hierarchy recommendation that visual processing depends on the integration of basic visual skills. Let's review a few quick points to remember when developing treatment tasks to address visual impairments in your patients. If your patient is experiencing visual discomfort during interventions, consider restoring visual skills to within normal limits in one eye at a time and then progression to biocular skills training. It is important that each eye functions well individually prior to them working together. The ultimate goal of visual rehabilitation is to achieve automaticity of visual function with meaningful task. Achieving automaticity would mean that our patient's visual system is integrated to a point where they are able to complete tasks such as ADLs or mobility skills without conscious effort or visual discomfort. It is usually the result of learning, repetition, and mass practice. Research shows that utilizing a multimodal sensory approach has promising results when paired with activities that address visual dysfunction. The easiest way to challenge other systems is by challenging patients' vestibular, proprioceptive, or cognitive system with each visual task. This can be done by having your patient sit or stand on a balance board or foam disc, standing on one leg, or adding a motor component while reciting items within a category. They can also attend to a metronome. Be creative and intentional with task selection. Finally, remember that all rehabilitation disciplines play a role in identifying and treating visual impairments. We should always maintain an open line of communication with the treatment team and discuss any changes we notice while treating our patients. Remember that as therapists, it is not within our scope of practice to make a formal diagnosis based on the results of the visual screen. However, it is our responsibility to refer our patients to the appropriate medical professional or visual specialist to perform a more thorough visual evaluation and treatment. It is within our scope to address our patients' symptoms of visual discomfort through the various restorative and compensatory efforts discussed today. We can also provide information to reach out to other community resources if available, such as an optometrist to provide guidance for the appropriate visual exercises and provide the appropriate caregiver education to ensure carryover and success for our patients. Thank you for your time.
Baton Rouge Rehab Hospital is proud to be a leader in inpatient and outpatient rehabilitation services in Baton Rouge and surrounding areas. We pride ourselves on a commitment to restoring lives through compassion and a dedication to excellence. As the frontline staff members at Baton Rouge Rehab, we achieve these goals and standards through a responsibility to attain the highest level of competence and consideration for the unique and specific needs of our patients. Participating in hospital-wide education and seeking out opportunities to learn and grow as an individual is what can set you apart as a top talent contributor to the hospital. The education provided to you today highlights the 4 values of Baton Rouge Rehab: compassion, integrity, teamwork, and excellence. When you take the knowledge you have gained and apply it to person-centered, excellent care, you are contributing to the excellence of Baton Rouge Rehab. Thank you for your dedication.